This was a C5C6 disc protrusion with myelopathy without radiculopathy. This is a head end, this is a leg end, that's a right side, and this is a left side. So this is a midline where you can feel the manubrium in between the two clavicles. Ideally it should be kept exposed while doing the draping. This is a chin, then this is a proper midline from here to here. So my incision is from midline towards the left lateral side, and I have exposed this from the left anterolateral approach or left side Smith-Robinson approach. This is a transverse incision after skin, subcutaneous fat and tissue, and then this is a platysma which you can cut via the monopolar. Monopolar should be kept at 30 or 35. When we do lumbar, we keep monopolar at 50, 60, but here it should be kept like 30. This is a sternocleidomastoid. Once you cut the platysma, then you get the sternocleidomastoid. You can clearly see the direction of it from medial to the lateral side like this. This is a sternocleidomastoid. And the main confusion starts when you identify the medial border of the sternocleidomastoid. Once you retract it, sister, right angle. Next important step is to feel the pulsations of the carotid, where I can feel these pulsations. But you see this muscle and whose direction is from like this. Its direction is like this. Give me pen feet. And sternocleidomastoid direction is like this. So you should remember that this is a omohyoid which comes from like medial above to the lateral downward. So this is a omohyoid muscle. Give me artery. Some surgeons prefer to like identify its fibers. These are clearly seen, the fibers of the omohyoid. Some surgeons likes to cut it so that the field is clear all the time. I prefer to like preserve it. My boss used to cut it and repair it after. So once you identify this muscle, then everything is clean. Then below you can palpate the pulsations of the carotid, which, sister, right angle, small one. So omohyoid is being retracted medially, and below that there is a esophagus. So all those structures needs to be retracted medially. Once you retract those structures medially along with the omohyoid, remove this, along with omohyoid, everything gets retracted, and this is a carotid. Pulsations can be felt very well. And then you ask your assistant to retract carotid sheath along with carotid towards the lateral side. So in ACDF, this retractor which is on the medial side should be retracted more, because we go from lateral side towards the medial. So esophagus needs to be retracted more, and this retractor should be kept relaxed all the time, because this is just a protection. You need not to retract more like from the lateral side. Once you expose that, then you get the longus colli and then the hills and valleys. Hills are discs and valleys are like vertebral bodies. Then you identify the level on the CM on the lateral X-ray, lateral shoot, and then you start your work. So we have done the C5C6 ACDF with a standalone cage. That's my cage. This is a C5 body, this is a C6 body. I prefer to use these right angles because intermittently you release the right angles and your structures medially, esophagus and trachea gets relaxed in between, and your carotid sheath also gets retracted, relaxed in between. So that's why I prefer to use this. And while doing closure, Edson, there is no need to put a drain, give good wash, and everything falls back. Like this is a sternocleidomastoid, this is a omohyoid, then there is a esophagus, and you just have to close it without drain with one subcutaneous layer with Vicryl 2.0 and then monocryl or ethylone 3.0 That's surgeon's preference. Thank you.